is how many hours would it take to educate students about medical issues covered in the 4 primary areas of this conference? Is how many hours would it take to educate students about medical issues covered in the 4 primary areas of this conference? 1 to 3, 4 to 6, 7 to 10, or many, many, many more than 10? I'll leave it open for interpretation unless someone wants to clarify that.
But then you don't know what the results mean. Howdy. How are you?
See you flat.
Good to see you.
Yeah, like a 3 hour. Yeah.
I should be saying that. Thank you.
Well, I didn't.
Great.
Okay, next question, please. Do we need to plan a follow-up conference to this conference? Number 1 is yes, number 2 is no.
Yes, in Hawaii.
We had a suggestion for Hawaii.
Then we had to argue about which island.
Fairly significant majority agree that we do. Okay, now it gets a little tricky. Next question. When should a follow-up conference be scheduled? 1 year away, 2 years away, 3 years away, or we just don't need one? And if no one answers number 4, we have to go back to the previous slide and try it again. Okay. About 54% say 2 years. And finally, this is the very tricky question. What is the maximum registration fee you would be willing to pay for a follow-up conference? You don't want to pay one, or you wouldn't pay one, I guess. $250, $350, $450, and you would attend regardless of the registration fee. And for our Canadian friend, this is US dollars. Okay, about what the registration fee was for this conference. All right, now I think that's all the questions we have for right now. Thanks.
Well, good morning, everyone. Welcome to the third day of the Health Promotion in Schools and Music Conference. And before we get underway here, a couple housekeeping items. One is for you to be aware that our lunch will be provided again today. It'll be a little different format. It won't be the box lunch, but it will be a buffet lunch, and with some Texas Southwest fare so that your belly's nice and full and be thinking about us here for the next 5 or 6 hours after lunch. And that'll be out here in the foyer. So if you're still wanting to powwow and meet as groups or subgroups or whatever, you're more than welcome to do that. But we have not arranged it like we did for the last 2 days, where there was sort of this formal designation as to where you would go if you were in one of those working groups. Then after lunch, we'll move into the consensus building process, and it should be an exciting afternoon. I'd like to take the opportunity, although I don't see him, he just left, to thank Andy, Krim, and Pam McFadden, who oversee the professional continuing education group at the University of North Texas Health Science Center. And they are primarily responsible for the logistical aspects of this conference. And people are coming up to me and saying, oh, thank you for developing this wonderful conference. And I'm looking and saying, well, you're welcome, but I really had little to do with getting the facilities arranged and getting the wonderful technology set up and having all these logistical things taken care of. And for those of you who have done conferences like this, I'm sure are aware that that's something that can be very distracting and very tedious, and often could be the demise of a conference. And like myself, I'm sure many of you are appreciative that this thing has gone smoothly. And I'd just like to have an appreciative clap for them really loud, because they're out in the hallway. Andy and Pam, thank you. This morning we're going to characterize and highlight 3 resources that exist on college campuses. We hope to understand these resources in a way that encourage us to utilize these resources and perhaps even influence these resources so that we can better serve our college musician community. I'd like to start this morning's session with a characterization of the College Health Center situation by Dr. Ralph Manchester from the University of Rochester.
Thanks, Chris. The slides you're going to see, again, are not in your notebook, and I apologize for that. They will be available on the website. But what I'm going to tell you, I don't think is information that you need to record for posterity. I hope what we can do is give you an idea of the kinds of services that are available at a variety of college health services around the country. You can compare that in your own little mental checklist to what you currently have on your campus, and then maybe make a note or two if you want about, well, gee, I hear that some places have service X, maybe we ought to look at getting that on our campus. But one of the major take-home messages that I hope you'll get is that there is tremendous diversity in college health services from one school to another. And I'm sure this has been stolen from some other field, but the saying is, if you've seen one college health service, you've seen one college health service. So what I'm going to cover is some aspects of the primary care services that are available, the first contact that students would have with the healthcare system on campus. Talk briefly about specialty care services that are available on some campuses. I'm going to say about 30 seconds about mental health care on campus because we've got another whole presentation on that. I'm going to talk for about 3 seconds about dental care because most of that does not occur within college health services. A little more about the health promotion activities that are available through student health programs, and briefly about complementary and alternative care, and then talk about some of the background issues. So primary care. This is, you think something's not as good as it should be with your health, and you decide as a college student that you ought to look into it. The primary care services available through a college health service are characterized by how it's staffed, what hours it's available, and in what locations, whether there is just outpatient care versus inpatient care, overnight care, and the ancillary services that are available, lab, x-ray, et cetera. Primary care staffing tends to be a mix, and again, this varies quite a bit from campus to campus, depending in part on the size of the school, number of students who need to be served, whether they are mostly residential students versus mostly commuting students. If they're mostly residential, they're probably going to be relying more on the on-campus healthcare facilities versus if they're mostly commuting, a lot of them are going to likely stay plugged into whatever healthcare arrangements were available to them before they enrolled. So to the extent that there are physicians in a college health service, typically the physicians are trained in family medicine, internal medicine, pediatrics, OBGYN, and some other specialties. Sometimes emergency medicine doctors go into college health, a smattering of others as well. Quite common in college health services is the use of mid-level practitioners, nurse practitioners, and physician assistants. This depends somewhat on individual state laws about the scope of practice of these healthcare professionals, but they're quite commonly present in a college health service. And registered nurses usually are an important part of college health service staffing as well, and they may have specialty certification in the field of college health. There is no specialty certification available for physicians or mid-level practitioners in the field of college health, and in fact, the college health certification for registered nurses is on thin ice right now, but may continue to be available. And then support staff are a vital part of any college health service staffing. These are the receptionists and appointment-making staff and record room staff and the people that allow the direct care providers to do their job efficiently. Now, within the overall primary care staffing, physicians and mid-level practitioners can be considered primary care providers. That is, the person who is primarily responsible for a patient's health care. And these are typically either physicians trained in family medicine, or also called family practice, internal medicine, or pediatrics, or a nurse practitioner or physician's assistant. As a ballpark figure, a primary care provider can take care of around 2,000 to 2,500 patients. So you can think about what the size of your student population is and have a fairly good idea of how many primary care providers you would need on the staff of your health service, at least from September to May, or whenever your academic year runs, in order to provide care. Now, this is assuming that it's probably a residential population that is getting most of their care through the student health service. Each primary care provider needs at least 2 to 3 support staff. This isn't just college health. This is in healthcare in general. And there's some indication that in recent years that number has actually grown, although the factors that are making it grow are less relevant to college health than they are to what we sometimes call the real world. Again, nurses play a critical role in college health services. On smaller campuses, it's often a nurse who's the director of the health service and nurses who are all of the professional health care staff in the health service. In that case, the nurses would often work with physicians and mid-level practitioners in the community to provide the range of primary care services that students need. Even in larger health services, nurses typically outnumber physicians and mid-level practitioners because of the wide range of services that they provide for students on campus. Many college health services do have extended hours of service available, at least compared to sort of a traditional 8 to 5 kind of office practice, providing access to care on campus during evening and weekend hours. Obviously, the exact sites of care depends on the geography of the individual campus. And some, but not all, college health services will have a healthcare professional on call after hours, providing 24/7 access to care for students. In cases where there is no healthcare professional, and it's usually a nurse or physician, on call after hours, then usually the arrangement is that students needing care urgently would contact campus security or public safety or whatever you call it on your campus for either transportation or help making arrangements for transportation to a local emergency department. Even though when some of us went to college, we may have even referred to the student health service as the infirmary, now most college health services focus on outpatient care, infirmary implying it's a place where you can spend the night if you're sick. The reasons for this include the cost of being open 24 hours a day when there is very limited utilization of the services from late evening hours until we could even say mid to late morning hours. The liability of providing inpatient care, especially when the kinds of problems that need to be dealt with, that is, let me start over. If something needs to be dealt with in the middle of the night, it's probably serious enough that it requires a fairly high level of care that's going to be more readily available in an emergency department than in the same clinic facility that's providing regular outpatient care during daylight hours. So with the emphasis being on outpatient care, there are several ways to do that. And some college health services do this strictly on a walk-in basis, which theoretically should allow for maximum convenience for students. You don't have to call ahead for an appointment. You can just walk in. Unfortunately, it's somewhat difficult to predict the hour-to-hour volume, and that may result in long waiting times once you walk through the door. Or care can be provided on an appointment-only basis, which means once you get there, it's less likely you have to wait, but you have to plan ahead and make an appointment, or it can be a combination of the two, and some will have care by appointment, but also run a walk-in clinic. Now, once a student gets to the health service and is seen by a nurse or a physician, oftentimes there's something else that needs to be done in order to figure out what's going on. And that can involve having laboratory tests, blood or urine tests, occasionally things like an electrocardiogram, breathing tests, a basic audiogram, and for vocalists with problems, looking at the vocal cords. Some college health services, typically larger ones, do have some of or all of these facilities. It's fairly unusual nowadays for college health services to have in-house X-ray facilities. Both the cost and the regulatory requirements are large enough that usually a college, all but the largest college health services will make arrangements for a student to have that kind of testing done in the community. Now, beyond primary care, A fair number of students, at least from time to time, will need to access specialty care. And again, larger college health services may have some medical specialists available to see students within the health service on campus at least a few hours per week. And this is often OBGYN doctors, general surgeons, sports medicine or orthopedic specialists, dermatologists, occasionally ear, nose, and throat physicians, and a variety of other medical specialties. In addition, some have on-site physical therapy. Athletic trainers are often available, if not through the health service, through athletics. Occupational therapists, dietitians are very helpful to have on staff to help students who are dealing with various eating and nutritional concerns. But again, in a smaller health service, these are typically services that are going to be referred out to specialists in the community. As I said, we've got a whole presentation coming up shortly on mental health care, but it is worth keeping in mind that on some campuses, mental health care is provided as part of the student health service. In other cases, there is a separate counseling center that's part of the college or university, but not part of the health service. When mental health care services are available through the student health service, staffing is typically a mix of clinical psychologists, clinical social workers, mid-level practitioners. For example, we have a psychiatric nurse practitioner on our staff, and psychiatrists. Psychiatrists are an expensive commodity in the student health care world and generally limited availability, but it is important to have some access to appropriate psychiatric expertise. Care is provided both on an individual and group therapy model, and it's often on a time-limited basis, and Don will tell you more about that. Very few college health services nowadays provide dental care as part of the program. I'm not sure why, because presumably college students should continue to get dental care, and for some of the wind instrumentalists, it's important from an occupational perspective as well. Some schools offer an inexpensive dental health insurance plan to help cover the cost. We hope that students continue to see a dentist at home or perhaps a dentist in the college community. That's probably something that we could do a better job of. Health promotion is an important and, while unique may be too strong a word, somewhat different kind of program than one would see in a typical primary care doctor's office. The college health service, in addition to providing direct individual care to ill or injured students, also has some public health responsibilities for the campus community. And these public health responsibilities are met in a number of ways. One is that in most states, all students have to submit evidence of having had certain immunizations before they're allowed to start classes. And it's generally the health service's responsibility to see that these requirements are met. This is not glamorous stuff, but until there were fairly uniform requirements across the states, there would be outbreaks of vaccine-preventable diseases, which in some cases, in rare cases, would be a big medical problem. There was actually a death due to measles at Principia College, which is a Christian Science college since I've been in college health. But it's a major disruption for academic life on campus. So this is, as I said, not glamorous. It's mostly processing paperwork, but it's something that is ongoing and with every new batch of entering students needs to be done. Typically, a college health service will ask entering students to fill out a piece of paper called a health history form, so that there's basic baseline information on the health status of each student as they enter. If there is an outbreak of disease on campus, it's typically the college health service's responsibility, working with the local health department, to address it. On the other hand, if there's an outbreak of disease in the community not affecting the college campus, primary care physicians generally don't get involved with that. They report the case of whatever it is to the local health department, and then the local health department takes over. If it's on a college campus, the student health service is, in most cases, going to be working long hours very closely with the local health department because of the unique environment of the college campus. And examples of this are if there's more than one case of meningococcal meningitis on a college campus, then there are guidelines that call for administering vaccine to the entire campus community. If there's a case of active tuberculosis, we happen to have one at my institution right now, then that's something that requires screening of the individuals who were exposed to the person with tuberculosis. So that's something that you may not see going on a day-to-day basis, but it's part of the health service responsibility. And then a huge part of health promotion for college students is the health education programs that a lot of college health services do. These are typically done either by health promotion professionals. They typically have a master's degree in the field, or in some cases by peer health educators, students who have been trained to do programs on specific topics for other students, and oftentimes it's a combination of the two. We have about 4,000 face-to-face contacts with students every year in health promotion programs. We have about 4,000 undergraduates at our institution. If you think about translating this to a community level, it's mind-boggling. If there are 100,000 people in a community, how can you arrange to have 100,000 face-to-face contacts as part of a health education program? Everyone living in the community having at least an hour a year face-to-face with a professional health educator. It doesn't happen in the community. It does happen on a lot of college campuses. Some college health services offer complementary and alternative medicine services. Things like massage therapy, acupuncture, Alexander and Feldenkrais lessons, and others. They are quite popular among our music students and our non-music students. Oftentimes, they are paid for separately from the core health service budget. So there may be special funding through the institution, or in some cases, it may be something that the student pays for out of pocket. So speaking of how we pay for things, most college health programs are funded on some kind of prepaid basis. So there's either a designated health fee that each student pays, or there's a line item in the institutional budget. each method has its pros and cons. If there's a designated health fee, then the director of the health service gets a few calls every year from students or parents of students saying, either I didn't use the health service all this year, I want my money back, or I don't plan to use the health service this year, I want my money back. And so we have an interesting conversation about how health care is paid for and how if you don't use your homeowner's insurance for a year, was that a good year or a bad year? On the other hand, if it's paid for as a line item in the institutional budget, then the health service is in there arguing with the music school and the English department every year about, well, who's getting the dollars. There's no right or wrong way. The point is, either way, it's much more efficient to pay for a designated range of healthcare services for a designated population up front rather than hiring additional staff to collect money from people every time they walk through the door. Plus, by paying for it up front, it removes the financial barrier to health care. College health services typically do not charge a copay for visits the way that most of us pay a copay when we go to see our HMO doctor. Recently, there's been some attempt to support college health programs by billing insurance companies. This sounds like a free lunch, but as we know, there ain't no such thing as a free lunch. You have to hire staff to do the billing. Students who are on an HMO plan but out of their home area often have trouble getting their HMO to pay for routine care out of their home area. It wasn't an emergency. So this has not been successful on any campus that I know of, but you still hear of places attempting it from time to time. I just want to take a minute to make a personal plea. And I think there's going to be an echo of this a little bit later about asking for excuses and working medical magic. It's very difficult for any healthcare professional to certify that someone was sick sometime in the past when the sickness has disappeared. You know, they gave me a crystal ball during medical school so I'd be able to do this, but it broke when I was moving to residency training, and I've been powerless in this area ever since. On the other hand, we're happy to make recommendations, and it's part of our job to make recommendations to patients coming in who have a problem that in order to recover from that problem, they need to curtail certain activities for a certain amount of time. So if we've seen them for that illness, then that's part of our job. If we haven't, then we would really urge faculty to deal with students as adults who can take responsibility for their own behavior and proceed accordingly. Likewise, we get requests from students to fix problems for them. And these problems might be, I'm in a double and I really need a single, or I'm on meal plan X, which is the full meal plan, and I don't want to be on the meal plan because the food in the cafeteria is terrible. Or I was sick last semester and I need to drop Music Theory 101. There are remarkably few medical conditions that require special living arrangements or meal plans that cannot be provided on a college campus. And if you just think about our own situations, I can't remember the last time anyone I know moved from one house in town to another house in town because of a healthcare problem. I'm sure it's happened sometime, but this is rare. So this is just an ongoing problem. Thank you for letting me ventilate. On to more important things. Confidentiality is a huge part of providing health care in any setting. It's especially important when we're providing it for young adults who are making their own decisions about accessing health care, typically for the first time in their lives. And even before the infamous HIPAA regulations, confidentiality was a major concern in college health. If students believe, correctly or incorrectly, that if they go to the health service will tell either faculty or parents or deans or anybody else what has been going on with their health without their permission, you can forget about having real access to health care on campus. So the general rule is we cannot release information about the care provided to a student without the student's permission. Now, one subtlety that I need to remind some of our staff about from time to time is this does not mean you cannot talk to a parent or a faculty member or a dean. There are people who care a great deal about the student who will, with either appropriate or inappropriate intentions, contact the health service and want to talk with someone about the student's problem. The prohibition is on us giving information to other people. There is no prohibition on other people giving information to us. That information may or may not be terribly useful, but just the process of communication is important, and we need to do that. So sometimes I hear, well, you know, just tell the parents I can't talk to them. No, you can talk to them. You can't give out information about the care provided for the student without the student's permission. With the student's permission, in general, we're happy to do that. However, I think you're going to hear a little later that in the mental health care arena, it's a little bit stricter, and it may not be quite the same. There's certainly concern about quality of care across the spectrum of healthcare in this country these days, and that should extend to college health as well. From what I've seen, quality of care in college health is at least as good as it is in the general community. I suppose you could say it's as bad as it is in the general community. Some of the things that you can look at as indicators of quality are whether the physicians on the health service staff are board certified for each of those specialties I mentioned: family medicine, internal medicine, pediatrics, all the others. There's a certification exam that you can go through by going through an approved residency training program, taking a qualifying exam, and nowadays taking a recertification exam generally every 10 years thereafter. You can look at whether the nurses are college health specialty certified, although, as I said, there's some question about whether that will continue to be available in the future. And you can look at whether your health service is accredited by the Joint Commission on Accreditation of Healthcare Organizations or the American Association for Ambulatory Healthcare. AAAHC is the more common certification for college health, but even combining both, fewer than 10% of college health services are accredited. There are lots of good college health services out there that are not accredited, but it does force you to meet certain standards and have that sort of seal of approval. Now, the bottom line as far as this conference is concerned is how much expertise is there in performing arts medicine in college health services? We heard, I think, in Chris's opening remarks on Thursday that there are about 100,000 students at NASM schools across the country. Anyone not in college health know how many college students there are in this country? Ballpark guess? No penalties for wrong answers? 3 million? 15 million. Now, this includes some people who are, it's full and part-time students. It's not all 15 million living on college campuses. It includes commuter students, et cetera. But that means that music students are less than 1% of college students nationwide. Now, that may not be true on your particular campus, and at the University of Rochester, Eastman School students make up about 10% of the total student population, and that's probably one reason why I'm here. But on the more typical campus, it's going to be a matter of resource allocation to get the College Health Service staff, or even a member of the College Health Service staff, up to a greater than community average level of expertise in performing arts medicine. One thing that I would suggest as a College Health Service director is that at least to get things going, you may need to look at whether there are some resources from the music school or music department that you could help the health service send someone to a conference like the Aspen Conference or one of the others. Now, there may be specialists in your community with expertise in performing arts medicine that you can take advantage of, but that's got some trade-offs in that there's going to be some transportation barriers if they're not right next to campus. There's going to be certainly some cost barriers if it's not part of the prepaid program, et cetera. And to wrap up, there are some resources that you can take a look at. The American College Health Association is the professional, not-for-profit organization, provides leadership and advocacy in college health nationally, and there are regional affiliates around the country. There's a peer-reviewed journal, the Journal of American College Health, which once, a number of years ago, published an article by Alice Branfenbrenner on performing art, on music medicine as relates to college students. There's an annual meeting coming up next May, June in San Diego, and there are regional college health meetings around the country, some in the fall, some in the spring. And there is a textbook published a couple of years ago called The History and Practice of College Health, and I found that on, I confirmed that you can get it through Amazon or another online type bookseller. And some performing arts medicine resources. You've heard several times about Performing Arts Medicine Association, its journal, Medical Problems of Performing Artists, and its annual meeting held in Aspen, usually in late June. The textbook of Performing Arts Medicine is a few years old now, and even its second edition, but it's still a worthwhile resource to have in a college health library if you've got music students on your campus. Those are the things I had prepared to say. I don't know if we want to take questions now or move on. Move on? Okay, questions at the end. Thank you very much.
hits it, right? I want to start by thanking Ralph. I hear almost every day students are telling me I'm not old, that I'm their parents' age, which they somehow think is comforting. And second, I'm not saying I'm old, so I don't know why they're doing it. But I never called it an infirmary. It was a health center to us. So I must be in the middle. So I'm going to talk to you a bit today about speech and hearing centers on university campuses. And I hope you'll find my stuff cutting edge because it's hot off the press, so I'm going to have to look at my paper, something that I never appreciate in a speaker. But for decades, departments of speech and hearing sciences at colleges and universities have recognized their responsibility to provide services to vocalists and instrumentalists. Graduate programs in audiology, for example, have included courses on noise for nearly 25 years. The 1980s, we saw a few universities offer courses in professional voice, and also a few different universities expanding their noise courses to include music and its acoustic properties. Advances notwithstanding, and with notable exceptions, universities have traditionally and continue to devote, at best, modest attention to speech and hearing concerns of amateur and professional vocalists and instrumentalists, and I hope to document that for you. Oh, look at that. I'm confessing. As evidenced by our scope of practice, our technical reports, our position statements, our knowledge and skill documents, and our certification requirements, we know that our role includes providing services to vocalists and instrumentalists. Consider, for example, a technical report. There's our roles. Mine are a little out of order. We diagnose, we do prevention programs as well as treat speech and hearing disorders. But in 1992, the American Speech and Hearing Association got together with the National Association for Teachers of Singing, and they recognized the interdisciplinary nature of the fields. And one of the things that they recommended is that both disciplines take coursework in the other disciplines. And then they treaded somewhat lightly on our respective roles, but agreed that we should work together. What does audiology offer? Speech documentation indicates clearly that they play a role with music, but audiology documents very rarely note anything about music. We have information about hearing conservation, measures of noise, room acoustic, and on an extremely rare instance do we see the word music. Most of ours falls under noise, and then we apply the concepts, but it's not recognized to the extent that it's recognized in SpeechPath. We have the expertise to serve vocalists and instrumentalists, but few of us do, and moreover, there's a very low level of interest in providing the services. Not at our campus, but at other campuses. I looked at the U.S. News and World Report which apparently is a good survey if you're on the list. Otherwise, it has all these flaws. But I looked at the top 51 ranked programs in speech-language pathology and audiology. Then I went to the websites to look at their speech and hearing centers. And of those 51 nationally ranked programs, only 12% mention hearing loss in musicians. Only 10% mention professional voice. And of the 6, 2 mentioned both. That's not a very big percentage. Then I looked at their academic programs. Nearly every one of the programs required a course in voice and its disorder, and for audiology, a course in noise or hearing conservation. But only 1 of 51 mentioned auditory processing of music, and it was a sophomore level course. Only 2 mentioned professional voice, and one of the 2, the expert in professional voice, just retired. So that may say 1 next time. The professional organizations did some surveys, and one of the questions asked, would you register for a program related to hearing conservation, acoustics, noise? 53% of 2,070 people said they would not, or most likely would not. Would you pursue specialty recognition in the area of occupational hearing conservation? 14% of 2,100 people said yes. We do have specialty recognition in the area of stuttering, but we don't have it yet for this. Okay, what types of services do we provide at speech and hearing centers? And we've mentioned this. We identify hearing loss, we diagnose voice disorders and hearing loss. We diagnose them as well as treat them, and one thing that I could add to that is we do prevention programs. What type of services does SpeechPath offer? Rigid fiber optic oral endoscopy, flexible fiber optic nasoendoscopy, and that's used to visualize, to visualize the vocal tract during conversation, during breathing, and during speaking. In audiology, we now have video otoscopy, so we can see the ear close up. We also measure hearing sensitivity, middle ear and cochlear function, speech understanding, tinnitus, and we have screening programs. In addition, we do hearing aid evaluations and dispensing. Dispensing is a fancy word for selling them. We have assistive listening and alerting devices. Those are the listening ones, look like Walkman type things often, and alerting are the lights that go off in response to sound. We also provide what we now call rehabilitative audiology, and we do assessment and fitting of hearing protection, which I made a little larger. We also offer courses. We offer courses that would be appropriate for undergrads from the School of Music: anatomy and physiology of the speech and hearing mechanism, speech and hearing sciences, speech and hearing disorders. We also offer graduate courses. We do have a lot of students from the School of Music enroll in our graduate courses, primarily the instrumentation. We also have hearing science, speech perception and acoustics, hearing assessment and diagnosis, amplification, cochlear implants, balance and assessment and rehabilitation, and hearing conservation. But for the most part, the music students take the top 4. What clinical services do speech and hearing centers offer schools of music? That was the question that they asked me to address today. And hopefully I did that to at least some extent, but I think it's the wrong question. I think the question should be, what might schools of music do to ensure that their colleagues in speech and hearing prepare and graduate professionals competent and motivated to serve vocalists and instrumentalists on campus and in the community. We have a history of not doing it. We spend a lot of time doing neonatal screenings and trying to get hearing aids to people that need them. And just like the population of hearing impaired or people with hearing loss in the health center, we don't see that many. And what we do see, we see in industrial screenings. So I think a lot of it rests with the School of Music. You need to do the advocacy. Call chairs on every other campus, because we have a noise expert on ours. What do we need for it to succeed? We need a plan. Then we have to implement the plan. We've got to assess outcomes. I won't belabor that because anyone affiliated with a university probably doesn't want to see outcomes assessment ever again. And the other thing that we need to do is we need to recognize the costs. Speech and hearing centers don't charge students, or they charge students a reduced rate. So when we decide to do something together, it can be very costly to the speech and hearing center, Chris. What are some things we can do? I made a list so that we could play nicely together. I will admit to being at that age where I can't see you without them and can't see this with them. All right. We could do research together. Here's some possible areas. Measurement of sound pressure levels at the eardrum, acoustic analysis of architectural structures, musical instruments or normal and disordered speaking and singing voices. We can do observations of laryngeal movements, determination of intraoral pressures, and quantification of muscle efforts during singing and the playing of musical instruments. We can also measure listeners' pitch perception, localization ability, reverberation, vocal quality. We have the equipment to do that. Many schools of music don't. You have expertise in that area, and ours is more limited. In addition, we sell hearing protectors for the School of Music. We see a lot of those students. So there's lots of opportunity, and it's been working very well on our campus. Dr. Chesky and Dr. Hennick, who isn't here, collaborate. And I have yet to be at a meeting where one of the administrators hasn't commented on that being one of the exemplary programs. The dean says it, and when we sent forward a list of shining star activities in the college, that was one that was sent forward. The former provost, addressed the chairs, and when he was talking about excellence on the campus, the music, speech, language, hearing program was, I know it's not called that, was the first thing that he cited. So at a minimum, if you knock on the doors of speech and hearing, someone may say you're doing excellent. I'm going to close by telling you who helped do this. When I say I looked up the web pages of 51 universities, I didn't quite do that. Will and Ian did. And this is my first day with PowerPoint. And she fell asleep about 2:30, so I got a little nervous. My daughter is the one that did the overheads, the PowerPoint. So thank you.
While we reset, it's been an hour. That's your limit for concentration. Take 2 minutes and go to the bathroom. See? Well, good morning. My name is Don Rosen. I'm the director of the Counseling Center at Texas Women's University, and I have a remote mic and a remote control, so I'm going to stay away from the podium. Woohoo! I have the technology, and I'm not afraid to use it. Okay, and I have the opposite problem. I can see you, but sometimes when I need to read, I got to go for the glasses. Okay, I want to talk a little bit about health services or counseling center services on campus. And I've got a variety of information, but just to give you kind of an overview. Just like health services, it's important for you to understand how counseling centers work. We're a little bit different than health services in many cases. And understanding kind of the legal and ethical boundaries we have to work in sometimes helps you understand why students report to you what they report to you when they go to the counseling center. Or will help you understand what happens when you call the counseling center. And so what we're going to talk about again is what applies in general to most counseling centers, although like health centers, almost everyone's a little bit different. Where do the differences come from? The differences come from a variety of things. Some is history at the university. Let me give you a good example of history. Some of you may be aware that several years ago, MIT didn't have a really good counseling center. And then they had that infamous incident with the student who committed suicide, and suddenly they have a much bigger, expanded counseling center. So historically, you know, sometimes it's by demand. Other times it's institutional priorities. Other times it's budgets. There was a hint about that earlier, and we'll talk about that a little later on. But also, state by state, laws change relative to mental health care, and so that's going to impact the kinds of services and things that are offered too. Okay, well, one of the things I want you to hear first is use us. We're usually the most underused resource on campus. And if the dollars that run the counseling center come from student fees, then we're just sitting in our offices getting paid for nothing. Okay. So let's talk in general about the kinds of services that counseling centers offer. Almost every counseling center offers some form of individual, group, and crisis counseling. How much of each, how long you can get at the counseling center is going to depend on a number of factors. A lot of it has to do with staffing and money. We'll come back to that all you need is cash line many times. But usually, in addition to sitting at home and offering services directly to students, we also like to get out of the office and be preventative by offering outreach programs and workshops. That allows us, as the health service will talk about their health education program, to give more information to lots more people, and hopefully some of them will even pay attention to what we say, which is not often true, but we also offer consultations with faculty, staff, and students. It's not unusual for us to get a call and say, I got a roommate who? Yeah, sure, it's your roommate, yeah. A faculty member will call and say, I got this really strange person in my class. Tell me what my options are. And staff members will do the same. Now, again, just like the health service, if you call and say, I want to talk to you about person X, if you want to give us information, we can listen all day long. If you want me to respond as if we're seeing them and we can tell you secret information about them, it's not going to happen. But if you ask us, if you had a student who was doing the following, what would you recommend? We'll talk to you all day long. Okay? So we can't talk to you about a specific person, but we can talk about a situation. We can talk about generically how we would address certain things. So we're happy to give you feedback, give you ideas, consult with you any way we can. within the limitations of our ethical guidelines. In other counseling services, you also may find things like testing services, which can include intellectual and learning disability testing. Career testing is a common one. Personality testing is another common one, although usually we do that in the process of counseling. It's very difficult when somebody comes in and says, "I'd just like to take a personality test to find out what kind of person I am." You probably already know what kind of person you are. And that's usually a loaded question. I will also tell you that historically, or as we move forward, I think you're going to see less and less of the intellectual or learning disability testing because it's incredibly intensive work. It takes a long time, and you know, time is money, and so it takes a lot of money to do that stuff. And so the more you get pressed to provide other services, the harder it is to provide things like disability testing or learning disability testing, things like that. But some places still offer it. Okay, here's some more things you need to know. We're going to talk about a whole bunch of things you need to know about counseling centers. One is confidentiality. Really, we mean it. By law, we can't tell anybody anything about our clients unless they sign a release form. That's true in all states. That includes attendance information. If you call me up and say, "Did, Jack get over to your office? I sent him over there," I'll say, "Can't tell you. Ask Jack. Jack can tell you whatever he wants. I can't tell you anything." Am I doing that to be mean? No, I'm doing that to prevent myself from getting sued and losing my license. Okay? So you have to understand, we take this really seriously. The students take it really seriously too. The easiest way to kill counseling centers is for the students to feel that it's not confidential. It's the death knell. So we do a lot of work to make sure that we don't say anything to anybody. And this is hard to understand sometimes, but even in imminent danger cases, counselors can be limited to the kinds of information we can give. In Texas, for example, if someone is in imminent danger, the only two groups of people I can call are the police and healthcare workers. Period. Not mom, not cousin Ellen, not significant other, not spouse, not children, not best friend, not roommate, not police, and health care. That's it. So confidentiality is really a difficult issue for us in some cases because people want to know what's going on, and we can't tell them. Okay. The other thing you need to know, or another thing you need to know, is we don't solicit. We don't stand on the street corner going, "Oh, you look like you need some counseling? Come to my office." Okay? We can't do that. It's unethical. We're happy to see people if they come to us, but we're not going around campus looking for students who are crying or people who look unhappy. We can't do that. So they must seek services, and we need the friends and the faculty and staff to understand that they can be the primary resource to get somebody who needs to talk to us. Okay? Consultations are welcome. I sort of reached this already. We're happy to talk to anybody in the community about how to make the community a better place, whether that's about an individual student, a group of students, a class of students, a department, the whole university. We love to nip problems in the bud because we know that the bigger the problem gets, the longer it takes to fix. And the longer it takes to fix, the more money it costs, one way or the other. The other thing that's also common is if we can consult with you, we can often talk you into an outreach program, which we can then come to your class to do. And I'll talk about outreach programs a little bit later in more detail. Okay, crises are welcome. I don't know of a counseling center where that's not true. If the counseling center is open and the student is in crisis, bring them over. Students love to be walked to the counseling center. If you say go to the counseling center, they may not come. Some will, some won't. But if you say, hey, you know, why don't we take a walk over to the counseling center? They'll go with you, usually. And you will leave them in the waiting room after they fill out their paperwork. You won't come in with them. And you can go back to your office. But oftentimes that's a simple way to get them over when they're truly in crisis. If they're not in crisis, then we encourage you to find out on your campus how regular appointments are made and to use that system. But if somebody's in genuine crisis, bring them over. Okay. If you can do a heads-up phone call to tell us you're on the way, that's great. So we know we can clear somebody's staff time. But otherwise, if you can't do that, it's okay. Just bring them over. Okay. Talk about this. We sort of broached this when we talked about health services. Third-party reports of imminent danger are difficult to respond to. Here's the classic. John went to the hospital last night and had his stomach pumped from an overdose. He's back on campus today. You should do something. Well, what we're going to do is sit in our office, write case notes, see clients. Because once John's been seen by a medical professional and judged to be well enough to be released, they're not in imminent danger anymore. And the only time we can act to intervene, to take somebody's freedom away, because that's what an intervention in imminent danger is, we can't do anything. We can't go out and solicit business. So information after the fact cannot be acted upon. It's very difficult. It's all right for us to know we got a student in trouble on campus, but if you want us to go out and take care of them, we can't do it. Okay? So imminent danger is a tricky thing, because imminent danger means imminent, now, not 2 hours ago, not yesterday afternoon, not tomorrow afternoon, but right now. Okay, this is a political statement. Disruptive behavior is best dealt with by the judicial process, not by the loony patrol. Every university has a student code of conduct which prohibits disruption to the university and threats, usually to others and sometimes also to self. Why do we care about that? Well, because if a student is having psychological problems and the way you recognize that is they're disrupting your classroom, there are all kinds of legal and other implications about why you don't want to say, oh, the poor thing's sick. Let's not make them be responsible for their behavior. Let's let them withdraw from the university because they have a psychiatric disorder or a psychological disorder. Well, the problem with that is the next semester you're going to see them in your classroom and they're going to be doing the same thing again because they got a free pass. And nobody asked them to change their behavior. So they're going to be back doing the same thing. And then they'll withdraw for psychological reasons. And then you'll see them in your class the next semester and we'll keep on the merry-go-round. If students disrupt the university, if their behavior is inappropriate, they can be held responsible for that. And if the university says, hopefully, if you behave in an appropriate manner, you can stay here. If you do not behave in an appropriate manner, you cannot stay here. Seems like a simple formula, but there's a lot of stuff that gets involved with, let's let the counseling center take care of this. I don't want to file a judicial claim against the student. So if I can get somebody else to take care of this for me, it's a lot better. That's the short run. The long run is it's not better. Okay. Here's a repeat. Counselors are not clairvoyant. I'm sending a student over for you to talk to. He's had a lot of things happen in this semester, and I want you to listen and tell me if he deserves a withdrawal or an incomplete. The words academic freedom mean anything to anybody in this room? Oh, okay, good. One person in the back. Okay. All right. You have the right as professors to decide who gets an incomplete or who can withdraw. It's none of my business. I'm not an academic. And the health service rule applies. If you didn't come in while you were sick, you can't come in later and ask for an excuse. So if somebody comes in and says, oh man, I got to tell you, the first 12 weeks of the semester were horrible. I was depressed, and my uncle moved out of town, and my girlfriend left me, and I couldn't study, I couldn't concentrate. Oh, but I'm okay now. Don't need your services. Just give me the notes so I can go back to the professor and he'll let me withdraw. How do I know? I can't know. So if you want to give somebody incomplete, give them incomplete. Or if you want to let them withdraw, let them withdraw. If you don't want to, it's okay. Choose a reason. You didn't do the work. I'm sorry. Okay. If you're unsure of services that the counseling center offers, ask the director. In this day and age, one of the ways you can get information, depending on what's going on in your university, is you can look them up on their website. There are a lot of good university counseling centers with really good websites now that provide all kinds of information. And if we had Wi-Fi in the room, I could show you ours, but we don't, so I can't. But ask the director, look on the website, get a sense of how the place works. Also, if there's something you think the counseling center can do that would be useful, talk to the director. This whole thing is about how we can provide services for your students. Well, one of the ways we can provide it is by you coming to us and saying, gee, I went to this great conference and got some ideas, and maybe there's some programs you can provide to our students. Here's the paradox. You have to decide in advance where your priorities are for your students. Because here's the classical call. And I'll use our nursing program as an example rather than the music school. Our students really need a workshop on stress management. Can you come out and do one? Sure. When would you like us to come? Well, let's see. They're out of class around 4:30 on Thursday afternoon. So how about if you do a program at 5 o'clock on Thursdays? Not mandatory. No. Okay. So how many of your students do you think are going to show up, remembering that 85% of our students are commuter students, most of them are married, many of them have children, and they've been through a long week? Gosh, I don't know. How many do you think are going to show up? Okay. Well, how about if we come to class? Oh, no, we don't have time for that. No. The curriculum's too important. We can't interrupt the syllabus for this. Forget it. Okay? So one of the things you may want to think about, and this conference is great to make you think about that, is are there things you want your students to know that may not be in the textbook, but that are important for them to be successful in the music program? And if so, how can you include that in the curriculum? Isn't that what the conference is about? Yeah, okay. So, some of you may choose, or the department may sit down and say, in which course do we want to make sure that our students get something on stress management or time management? You know, they're in labs all day long, they go to classes, then they got to go to work. How the heck are they going to get their homework done? So there are all kinds of things that we can provide to students, but if they don't show up, it doesn't help. So if we can go to classes, we have what I call butts in chairs, and we know they'll be there, okay? Okay. The other thing goes back to some things we talked about here. We're back to all you need is cash. Even more than music programs, counseling is a labor-intensive endeavor. We only see, except if we're running a group, and we don't do those much, one student at a time per hour. You go to therapy, you talk for an hour, okay? So remember how we talked about a primary care physician can handle about 2,000 to 2,500 students? We can't do that. There isn't that much time in the year, okay? One student an hour per counseling center member. That means that, relatively speaking, our services are really expensive for the university to maintain. 91% of my budget is salaries and fringe benefits. I run my office on this much money because the rest of it goes to salaries. That's what we do. We meet with people one-on-one. So if you want to know why there aren't more counselors at your university? The first reason is it's expensive. That doesn't mean I don't think it should happen. That just means it's expensive. And so, again, in universities where the counseling services come out of general university operating funds, then we are competing for the same pie that you are. And I got to tell you, historically, faculty members have been really happy to say, you know, if it's a case of me getting more money or the students being able to have some counseling services, give me the money. Okay? Counseling, you don't need no counseling. It's a college student. So there's this dynamic tension always between where does the money come from and how many students can we see. The other thing you need to remember is students do not always wish to change. Some of you may have experienced that already. But if you send them to the counseling center, that doesn't necessarily mean they're going to come back cured, okay? Because there are all kinds of intervening variables. All right. Let me talk about resources that are available even as we speak. On-campus resources, internet, and other resources. On campus, you usually have some kind of university counseling center. Sometimes it is in the health service, sometimes it's separate, sometimes it's stuck in some organization because somebody decided it was a good place. But usually somewhere in the student life area in most cases, and sometimes in the academic area, and sometimes in the business area, and sometimes in the... You'll find a counseling center, or at least a counselor who does personal counseling rather than academic advising. Mostly, we're staffed by licensed mental health professionals, psychologists, licensed professional counselors, licensed marriage and family therapists, licensed social workers. There's a couple of others that I'm forgetting, I'm sure, but people who are licensed by the state to provide these kinds of services. Centers vary by size, type of service, provided number of sessions that can be given on a free basis. But there are, at the very least, some place you can go at the university to at least get a referral for other services if you need them. In some places, the only thing the counseling center does is meet with a student once so they can say, okay, now the place you really need to go is into the community to pay for therapy, or over here to do this, because that's all the university is affording for the counseling center to do. In other places, you can get unlimited individual therapy for your whole life. Isn't that a great bargain? Whew. Okay. Also, in addition to counseling centers, there are other clinics and things. You often see other kinds of clinics. If you've got a big psychology training program, you will often see a psychology clinic, or a marriage and family therapy clinic, or a counseling clinic, or a social work clinic. Those are typically open to the public on a sliding fee scale, but they will also see university students. And the general rule of thumb is, if you go to one of those clinics, tell me you're a university student and you have no money, they'll charge you next to nothing, like less than $5 a session, okay? And of course, the advantage is they're on campus. They're usually training programs for students in those disciplines, but they all have to work under the same ethical guidelines and supervision guidelines that the rest of us have to work under. There are also adjunct services that were already mentioned. Many places now have wellness centers. There are health education services. There can be dietitians. There can be the campus ministry, which is often a thing we forget about, but students may come with an affinity to religiously based kind of counseling. And if it works, it's okay. If that's the place they want to plug in, that's good, because if it gets over the head of the person who's talking to them, they know about us. They'll refer them to us, just like we refer to them when a student has a religious question that we don't want to get in the middle of. Okay, so there are all kinds of services on campus. Let's talk about internet and other resources. Internet resources are really moving. I mean, every day there's a new website. So I can't give you a complete list, although in your book you've got these slides, and so the websites that I'm about to talk about are available, and they're listed. Okay, there are two types of services: informational resources and interactive services. Internet informational services are really good now. They really are stuff. So the first one I'm going to mention is the American Psychological Association Help Center. The website's up there. it's for the general public. It's for people dealing with issues. When the Iraq War first broke out, or was it at 9/11, they put up a lot of stuff about dealing with major trauma and stress because the whole population was going through that. There's all kinds of stuff on depression and anxiety and how to find a provider and all kinds of other things. There are some university-specific websites. One of them is Campus Blues, and you can see that it's there to help students. Typically, the way this one and the next one I'm going to talk about work is the university has to contact them and register with them. There's no fee. There's no real downside to it as far as I can tell, but you're listed on their list of universities who are participating, and it also usually allows you to have them link back to you. So if a student wanders onto this website and says, this is great, and one of the things you can get is information about local resources, then if you type in your university, it'll link you back to our website page. Okay? So we're all working together here. So Campus Blues is one. And the other one is a creator from the Jeb Foundation. You might be aware of that. It was a student who committed suicide on a university campus, and parents got together and created this foundation. And again, it's the same kind of process. Lots of good information, all aimed, at least in theory, to be counseling students or college student friendly. University Counseling Center information is available, sort of compacted, at least the handouts that are available, in a place called the Virtual Pamphlet Collection. Somebody who's a lot more compulsive than me got together and linked all of the University Counseling Center websites that had handouts available into this one place. And so when you open this up, what you see is a topics list: anxiety, depression, time management, test taking, reading, on and on, relationships. And you click on that, and it gives you a list of 30 or 40 different handouts from 30 or 40 different universities, and you can click on that, and it'll take you right to the site, and you can print it out. So that's available as well. The other thing that's growing, and some of you may have been seeing this on campus because it's depression screening week or month on most campuses. The Screening for Mental Health folks provide screenings and information to colleges and the general public for alcohol and drugs, anxiety, depression, and eating disorders. You can do it in several ways. One is you can decide which of those 4 are most important to you, and you can pay individually to have printed materials sent to you and then physically set up a screening place on campus for that one day and do it. The other way you can do it is by paying instead for year-round access to their online screening process for all 4 of those. And so if you go on our site, you will find a link which takes you there and allows you to screen yourself for any one of those 4. And if you come up with a score that for them says there's some things you need to think about, then it refers you back to our counseling center. So if people have general questions about, well, do I really have an alcohol problem? How anxious am I? How depressed am I? Do I really have an eating disorder? They can actually go online, screen themselves 24 hours a day, 7 days a week, anywhere they are. And do that. Okay, I put this in red because I wanted to make a statement here. Interactive services. This is online counseling. Give us your credit card, we'll talk to you. This is not regulated by anybody. You don't know who's on the other end of the keyboard. You also, regulation of therapy is state by state. So if I have an online service and the person I'm talking to is in California and I do something they don't like, it's too bad for them. Because if they go to the California State Board is going to say they don't live in California, they're not under our jurisdiction. And if they go to the Texas Board is going to say, wait, you live in California, right? Well, you have no standing to come to the Texas Board. So there's no regulation of this at all. So my opinion is avoid it. at least for now. We're not at a place where we're advanced enough to really know how this stuff is working and whether it's working at all, and the best thing to do is not. Okay, so in summary, other campus resources and counseling centers are there. Other resources are available through the internet. And what we really want you to get here, speaking for the Association of University and Counseling Center Directors, is come talk to us. Let's work together. We want to do that. We want to find ways to come to your classes and talk about things that are important. We want to be available to consult with you when you have issues that you're struggling with. And we're happy to do that because that's why we get paid. Okay. So that's me, and I guess we're going to go to questions? Yeah? Just in case you want to go look at our website, because one of the things we have online is the workshops we typically do. We actually put our stress management, time management, assertiveness, depression, how to talk to your professor, all those kinds of workshops. We created PowerPoint presentations, and you can actually put them on the web. So they're available, and if you want to go to our website, I'm not going to give you the whole thing because you'll never remember it, but if you go to www.twu.edu and hit the directory and go to C for Counseling Center, you can find our website. And you will find our online workshops as well as a variety of other things if you care. And if people want to know, just link to our sites if you want to use that stuff. It's okay. All right, I'm going to sit down and we'll answer questions. Anybody? Oh, okay.
I believe in the power of words, and I also believe that sometimes wise and sage advice comes from sources that may be obscure and people who may be obscure. So having said that, I want to ask a question about stress. It seems as if stress may be epidemic, and yet what I'm seeing also is the use of the word stress is epidemic in the lives of faculty and students. Having said that, one source by Leslie Hart, Human Brain, Human Learning, gave me an inkling of how to reword, reframe stress into, he makes a distinction between stress and pressure. That gave me the idea of helping students stop naming everything they were feeling as stress. So in that reframing, I think it has been certainly helpful for me, and I believe helpful for students to name it as excitement, fatigue, coming up with other descriptions for what they're feeling so that in using the term stress every 3 sentences, they are not actually creating more on themselves by naming it that. So having said that, my question to you is, does that make you shudder to think of reframing, renaming stress?
Oh, everybody's looking at me. Okay.
I'm looking at all 3. What do you have a response? I'm curious.
Yeah, I do. On the one hand, there may be some value to giving people other words to sort out exactly what's going on. The simplest definition of stress is the amount of demand being placed on you at that particular moment in time. And how much a person perceives that is depends on them and their history and their experience. So 2 people in the same place at the same time, different levels of stress. The difficulty of always trying to move it out of that realm is that we know that there are long-term medical consequences of ignoring it, of treating it as if it's not a regularly occurring event that you need to control on a regular basis. So for example, the simplest thing we see is when students go home at the end of a semester, they all get colds because they ran their bodies down so much that they're susceptible to whatever's floating around in the environment. That wouldn't have happened 8 weeks ago or 10 weeks before because they wouldn't have been that run down because the demand on them wasn't as cumulative as it was when they get to finals week and then go home. That's the simple thing. Long-term effect of stress, and you can talk about this all day. I mean, what we tell students is, if you want to know what the long-term effect of not dealing with stress is, look at the generation in your family ahead of you and see why they're going to the doctor. Heart attack, stomach problems, irritable bowel, migraines, ulcers, high blood pressure. So there is some need to say on a case-by-case or a day-by-day basis, is this really about how much you've been carrying for how long, or is this about a particular individual event which will end and then you'll be fine again? That's hard to sort out sometimes. Does that make sense?
Yes.
Okay. Not the answer you were looking for, though, was it?
No, it's just a longer conversation
Yeah.
for me.
And you would be surprised how many students we see that have illnesses related to long-term stress on our campuses. It's incredible. We've got a lot of irritable bowel syndrome on campuses. We've got a lot of 18-year-olds with ulcers. What the heck is an 18-year-old doing with an ulcer? It's not from eating too many chili dogs. So there's lots of good information out there that students are coming having their bodies tell them enough's enough.
Good morning. First of all, I want to thank you very much for this session. This is extremely helpful. I'm Karen Dempsey. I teach at William Patterson University in New Jersey. We have 20 full-time faculty. I'm one of 5 designated faculty as advisors. We have 250 music majors. I just want to set up the scenario for you. What can we, as faculty members, and particularly as advisors, provide for you in terms of information about a student when we refer that will be most helpful to you? And let me clarify, crisis or non-crisis situation.
I think that the first place to start is to talk about behavior rather than labels. We want to know what you're seeing that concerns you. They come to class, they sit in the back, they don't pay attention, they're crying quietly to themselves. And that's the concern. Or here's what the student has told me. Probably that's the most we need, because really what we want to do is just get them through the door and get them started. Almost all students are good self-reporters. We have a few that, but most of the students we see are really good self-reporters of what's going on for them.
Thank you. I asked the question because I have had mixed responses from our counseling center. Some probe and ask me for further information. Some stop me in mid-sentence and say, fine, just send them over. I'll handle it.
Yeah, and that's a stylistic difference. And there's no, I can't tell you which one's going to do it because everybody's different. Some people just want to experience the client as they see them and not have any, stuff coming from the outside. Other people just really want to know. And either way's fine. I wouldn't feel bad either way. I don't think it's meant to put you off or to not regard your information. It's just the experience and the training we come from and how we want to deal with it.
Thank you. I have one more question. How to handle the situation of a parent calling, sometimes in great distress, asking to not inform the student that the parent has called, but here is my son's, my daughter's situation. What do we do with that information?
I have a great answer for you. The first thing is we regardless of what your student code of conduct says or does not say regarding your need to maintain confidentiality between you and the student, and in most cases you don't have that, you certainly don't have it with parents. And it's okay for you to say to a parent, even though you think it might upset them, I'm sorry, but the rule at the university is if you want to give me this information, I'm going to have to attribute it to you. So that's the first thing. If they don't want to tell you then. But the other thing to remember is, I talked about all the limits we have on what we can do and what we can't do and how we can't bop people on the head and drag them into the counseling center. But the VP for Student Life or the Dean of Students, depending on your college, doesn't live under those restrictions. And so when we have a parent call who's distressed and they want us to do something and we can't, we say, but here's who you need to call and talk to. And we transfer them over to the Vice President for Student Life office, and they have a long chat with either the VP or the Associate VP, and they usually pick up the phone and call the student and just have them wander in and say, somebody's concerned about you, let's talk.
One other resource to consider is, depending on the circumstances, it may be appropriate to call someone in the health service. And it may be that a member of the health service staff has a relationship with the student, and depending on what the parent has said about, either don't ever tell the student that I called, that may be another opportunity to at least help get the ball rolling with a student who's struggling. And some students are reluctant to go seek mental health care, but are willing to come into the health service, and we can talk with them and sometimes help facilitate that referral, or can at least make sure that there's no imminent danger and arrange to see them again in a couple days. And if things aren't any better, usually if the student's willing to come back and talk some more, they're on a path to where they're going to make a decision about getting some definitive help.
This is just a quick question that probably doesn't have a quick answer, but some schools are a part of a larger system that supports a medical school and a university hospital. Does this affect the availability of resources?
Yeah, this is one good example of the, at least as far as student health services are concerned, the variability from one institution to another. University of Rochester does have a medical school that's part of the system. And on the one hand, that does make a wide variety of specialists in just about any field that a student would need to access available in close geographic proximity. On the other hand, those specialists, subspecialists are not part of the student health plan. So in order to see one of them, the student is going to have to find out what their insurance coverage is. Is their insurance plan going to cover a visit to this specialist in Rochester if they're from Texas? As opposed to, say a music school that's in a more rural area or where there is no teaching hospital nearby, it can mean that at least there's less of a geographic barrier. I don't know if there's more on the counseling side, but the same thing would apply to mental health services.
Well, yeah, and that reminds me of something. It's one of the things that you may or may not be aware of that you don't really need to be in some cases is the state of mental health in your state. In Texas, for example, since we have a $10 billion deficit, one of the places that has been cut and cut and cut is community mental health centers. So we have a place to send indigent students, but they're not going to get any treatment because they're not bad enough to fit into the treatment population, because as the money shrinks, so does the treatment population. Can I do anything about that? No. Because the only two options are you go there and hope that they take you, or you find the money to go see a psychiatrist on your own. And so in a lot of states that may be the case too. So resources are very difficult and getting tougher.
Question for Dr. Rosen. You made a reference to walking a student over when they show up in your studio in crisis. And having been a teaching assistant at one institution and gone through faculty orientation at two more, and feeling like I have a pretty good handle on signs and symptoms of general mental illness and disorders, I don't actually know what it looks like for a student to be in crisis, short of a student saying that they're contemplating suicide, which but that's a fairly clear one. So the first question is, what are those signs and symptoms? And the second question is, would you recommend that we're clearer on something like the preliminary recommendations for faculty that the Mental Health Board put together, where under item 9 they say educate yourselves about the signs and symptoms, and actually go farther than that and say, and you need to know what it looks like for a student to be in a mental health crisis?
There are lots of things on the web available that do, signs and symptoms and how to deal with distressed students, and the problem is every case is different. In many cases, a mental health crisis, as we define it, is a student will walk up to a professor and say, my grandmother just died, and start crying. And for them, at that moment, that's a crisis. Because that may be the first person in their life that died, and they were very close to them. And when I say crisis, I'm not thinking of the extreme ones that are easy to tell. They're talking word salad and they're sitting on the floor dithering. But rather, students will, because they have more contact with you and may feel comfortable with you, come up and tell you what's going on. Here's why I missed class yesterday. My boyfriend beat me up. Gee, why don't we go over to the counseling center and have them talk with you about what your resources might be? So when I talk about crises, I'm not necessarily thinking about way down at the long end of the spectrum, but rather self-reports by students who clearly show you they're in some level of distress. Yeah.
I've got one for Dr. Rosen and one for Dr. Coakley. Dr. Rosen, you mentioned how are we going to educate our students about stress, or what kind of format can you do that? I just wanted to mention at our school we have, and I think most music schools have convocation time, which is an hour a week where all the students meet at the same time, and it's a captive audience. We'd love to have you over to talk about stress. I've done it myself for the students. We've already implemented a stress management program. So I know if you called the dean of the school of music at your school and said, gee, can we come over and talk about mental illness, alcoholism, whatever you wanted to, that would be great. And it would be certainly implementable now because of the NASM regulations. So that would be great.
Good.
And Dr. Coakley, the joint statement you mentioned about NATS and ASHA, being a member of NATS and also ISHA, because I'm a student speech pathology major as well as a faculty member, I think that their goal of that statement was actually for faculty members to become more involved in teaching joint courses and being models to students. So the students at Western Michigan have seen me in class with them learning, and my boss actually gave me 2 years off of my job so I could get my degree in speech pathology. And shortly when I'm done with my practicum, I'll be able to scope the students, and we'll have more people scoping and doing joint things with each other. So I don't know, what do you think about the practicality of that?
Yeah, that's what I did say. And that's what the course that the music students come over to take, the one that they get to practice scoping. It seems very reasonable. The thing that I see as a chair, that if they're team teaching, that's a full course of teaching, even though they're teaching half-time. And
right. I know it speaks to issues, but if we really want to implement a health prevention maintenance program into the music school, we need to use our resources, the current resources we have. So those people who have voice programs on your campuses, deans, consider finding that voice faculty person who has an interest in speech pathology And if you already have a speech path program on your campus, you've got a gold mine. You really do. And you can link with that program and use it to the best of your benefit. So, okay, thanks.
I had a question for Dr. Coakley. What's your experience in talking to music students in a kind of 1 hour workshop setting about hearing loss from the anatomical point of view? I'm saying this because we've got music and medicine posters all around the music building with a picture of the cochlea with the destroyed hair cells, and that really makes an impact.
I don't want to walk down any street where I'm going to end up doing an hour talk. I haven't spoke with music students. I've gone over and lectured in physics classes and in psychology, but it's the same notion.
Do you think it would be beneficial to give these kinds of talks to maybe studio classes or instrumental methods courses?
Yeah, I think it would. And the other thing with our program with the doctorate now, we've got lots of resources that doctoral students could do them as well, and good opportunities for them.
Thank you.
I want to add something to what Don was saying. Don at Texas Women's University is on one side of Denton, and UNT is on the other side of Denton. And Don runs a great shop and does a lot of really great outreach and aggressive advertising to faculty and staff about outreach. But one of the slight differences I want to push is that I think when you look at your counseling centers, you're going to find that most of the folks there are going to identify themselves as generalists. And one of the themes of this conference is to work with and make referrals to providers, whether it's a medical provider or a counseling provider, that has some sense about music and the performing arts. So what I would encourage you to do in terms of your counseling center is to do like Don suggested, track them down and talk to that person, and not only ask for services, but see what you can do to teach a generalist what music is about. I can't tell you as a counselor how much I've learned by sitting in on departmentals and auditions and master classes and on and on and on, and riding the bus to Nashville with a country and western band. But all of that helps me know a lot more about what a musician is like, and consequently I can use the vocabulary of a performing artist. And this really speeds up the work, really speeds up the work a lot. The other thing, one other comment that I would make, Don was talking a lot about consultation with faculty and staff. We get a lot of consultation requests because a kid won't come to the counseling center. They have this great working relationship with their teacher, but their teacher is slightly up against the wall, not knowing what else to do. I can't tell you how many times I talk to a teacher about how they can continue a counseling relationship because the kid won't come to me. So don't be afraid to ask, this is my bias anyway, don't be afraid to ask for that kind of coaching for yourself, because I'd sure rather have you talk to the kid that little extra bit of the way than say, go see John Hipple and then him never show up. But that's what I wanted to add. Thanks for the time.
And I think there's one more piece that goes along with that, because it's the flip side. When you send people to any of us, all of our work is based on relationship. We're not going to be equally as good at having a relationship with every student that walks through the door. It's just not possible. You already know that about your students and the way you interact with them, and the same is true for us. So the typical problem that we see is, so you actually get them to come over to the counseling center, and of course they come back and report, well, I saw somebody and I didn't like them, so I'm not going back. I saw a physician who didn't want to listen to me, so I'm not going back. I went to the therapist and they were, and so I'm not, okay. One of the things that you can always do is say, okay, so you didn't have a good experience with this one person, perhaps. Would you be willing to at least either talk to them about the fact that you didn't have a good experience and see what the two of you could work out, or go back and talk to the director about being seen by somebody else? Because we want them to keep working on it, whatever it is. And if one person isn't going to be able to do it, and as a director, I know that happens with my staff all the time, and that's okay. They don't get their pace, reduced because of that. Then that's going to keep people in the system, and that's going to work better. But we know a lot of faculty on campus who will say, oh, the counseling center, man, I've had students go over there and they just come back and tell me how awful it was. Well, some people are going to feel that way. The key is to send them back and try and get them to re-engage us, because usually if they do that, we can make something work for them.
I have two questions. One has to do with the orientation process that's used at the schools for new students, to let them know what kind of services that you can provide and what the depth of those services are, how they can be accessed. And it has to do with orientation for both students and faculty, such as new faculty. And that's one question. The second one is, are there any collaborative partnerships that colleges can have with their own medical schools or dental schools for getting services for students at the school with the existing either medical or dental school in that university, or a partnership with another university or college nearby? Is that even feasible? So those are the two questions.
One first. Yes, there is the potential for making arrangements so that students can get services from the medical or dental school that can be part of the university. There are, I think, 125 medical schools in this country, and there are over 3,000 institutions of higher education, so that's not going to be the case at most schools, but still at a lot there will be, and they tend to be the larger schools with more students. You should be aware that just as budgets are tight for universities in general, budgets are tight for medical schools, and one of the ways that medical schools have responded to that is to tell their faculty to increase their clinical income, which is a matter of seeing more patients and charging what the market will bear. That puts some pressure on the programs that provide care at a discount, such as seeing students who don't have a lot of pocket cash. So it's certainly worth exploring. I wouldn't want to start that exploration believing that this is a slam dunk kind of solution to a problem that, as Don said, is a resource allocation problem. And if I can be permitted to make a bold statement, this country has not come to terms with a rational plan for providing health care to all of its residents. And I am getting increasingly frustrated with our country's inability to do that when every other industrialized country in the world has figured out how to do it and has better health outcomes for its citizens. I mean, not every country does, but we, despite spending the most money, we are well down on the list of the standard health outcomes, and this is especially a problem for the adolescent, young adult population who have some of the highest rates of lack of health insurance, and we struggle with this every day in college health. It's even worse for mental health, but even for straightforward routine medical care, hopefully your university requires all students to carry health insurance, but even when that is the case, as we have discussed, coverage for out-of-area care in an HMO plan is, in many cases, essentially not having health insurance. Having said that tirade, I forgot your first question. Orientation, right. I think most college health services do a pretty good job at
orientation programs for entering students. This is something that the health education or health promotion staff typically takes responsibility for. And during summer orientation programs or the week before classes start when new freshmen and graduate students arrive, they're running nonstop doing orientation programs. And then, obviously, it's not just a one-shot deal, but that's the captive audience time. I don't think we do as good a job orienting new faculty, and that's probably something that we could do better. I think students are obedient, faculty are not. I think managing faculty is like managing doctors, which is like herding cats. So that's something that we should probably pay more attention to in the future. And I don't think it's a matter of sitting all the new faculty down. I think it's a matter of sending some information out to them and then telling them how they can get information on an as-needed basis.
I would agree with everything that's been said, and I think one of the difficulties with orientations in general is information overload. No matter whether it's students or faculty, you're in a process where people are throwing information at you left and right, and it's very difficult to actually get people to pay attention. One of the things we do is, instead of going in front of the students who really don't want to know about counseling services for the most part when they come for orientation, is to talk to the parents and say, here are the resources that are available to your child on campus. Here's a list, put it on your refrigerator, and remember I said this, so that when your child calls, you can say, here's the number to call. And with, HR runs our faculty orientations, and they don't even tell us how to get hooked up so we can get paid. So, it's a whole other story, but okay.
I have two questions for Dr. Coakley. One of the big challenges facing us as music educators is trying to obtain data